Welcome to our webinar today. It's about the Ohio Talk, which is Transforming Adolescent Care Learning Collaborative, which is an initiative of the Ohio chapter of the American Academy of Pediatrics, or AAP, which aims to increase the comprehensive adolescent well-care visits in primary care. Our presenters today are going to share about the Talk experience, what it is, what led to it, what role it's played, its impact, things like that. Also, how the adolescent well visit is used as a framework for the range of care that youth need. And finally, the role that partnership has taken to leverage and maximize opportunities for this work. Next slide, please. So this webinar is part of the Creating Youth-Centered Care Learning Community, which is brought to you by the Adolescent and Young Adult Health National Resource Center, which is a partnership between 3 universities, California, San Francisco, Vermont, and Minnesota, where I am, and the Association of Maternal Child Health Programs, or AMCHIP. Our work is to support the work you're doing to improve access and quality of youth-centered care. My name is Kristen Teipel. I direct the State Adolescent Health Resource Center at the University of Minnesota and one of the National Center partners. I'm here with my colleague, Rena Large, who's working in the background. Next slide, please. So our learning community is really an opportunity to learn, talk, and think through how we weave together standards for health care with the qualities that young people demand. So in essence, it's good clinical care done in ways that connect with and meet the needs of young people. That's what youth-centered care is all about. Next slide, please. Through this, we pay attention to 7 different areas: access to care, providers and staff having the attitudes and skills so that they can interact effectively with young people, that our care is driven by guidelines that are evidence-based and offered in ways that protect and maintain and support confidentiality, that strategic types of communications are used that are in relation to how young people communicate with us, and that care is provided in spaces and ways that are welcoming and inviting for young people. And finally, that young people are involved both in their care and helping us shape healthcare that reaches them. So our example today from Ohio touches on many of these points. As you listen, I really encourage you to think about how all of this fits with what you're doing, what you'd like to be doing, or how you're helping other people to do things. Next slide, please. So we're joined today by 4 amazing presenters. Michelle Dritz is the adolescent medicine physician at the Cornerstone Pediatrics in Dayton, Ohio, where she cares for adolescents and young adults. In addition to her clinical work, she's the Talk Program Director, a member of the Ohio AAP's Committee on Adolescent Health, advisor to the Ohio Department of Health on their MCH and adolescent health work, and a clinical assistant professor in both the pediatrics and community health at Wright State University Boonshoff School of Medicine. Finally, she's also a founding member and previous co-president of the Ohio Adolescent Health Partnership, a statewide consortium of providers, government agencies, and community organizations that work together to maximize health and well-being of Ohio adolescents. Second, we'll hear from Samantha Ansel, who is a quality improvement consultant for the Talk program. She's been with Talk since the inception, where she drives practice improvements through team-specific data and feedback. She's been with the Ohio AAP since 2013, in which she's worked not only in the Talk initiative, but on 7 other quality improvement collaboratives on important issues such as obesity prevention, immunizations, screening practices. She's also a member of the Institute for Health Care Improvement. Our third presenter today is Elizabeth Dawson, the Chief Operating Officer of the Ohio AAP, where she's also the program manager for both Talk and the Quality Network of ADHD programs. She's managed, in addition, preschool vision screening, Pound of Cure, and the chapter's Quality Network asthma programs. Through all this work, she brings expertise in medical education and working with physicians in training and recruitment to lead all of the CME and MOC Part 2 efforts for the chapter. Our fourth presenter today is Laura Rooney, who's the Adolescent Health Program Manager for the Ohio Department of Health, where she's worked for 7 years as a leader focusing on school and adolescent health topics. She provides staff support and more to the Ohio Adolescent Health Partnership, which you'll hear more about today during today's presentation. In addition, she's the past president of the National Network for State Adolescent Health Coordinators. All in all, an impressive group of presenters. So welcome. Next slide. I'll turn this over then to Dr. Dritz to get us started. Thank you.
Hi, thanks for having all of us today. So I'm just going to start off the few sets of slides in conversation, but I'm going to be handing it off to Sam and Liz and Laura, just like Kristen mentioned. And hopefully, over the course of our presentation, you'll leave with a better sense and have a better sort of understanding what the TALK program is and certainly its impact in Ohio. But even more importantly, as Kristen kind of mentioned, sort of how can we take this type of information, these types of connections that we're making with TALK as being the example in Ohio, and really help all of your states in thinking about where are those connections and how can we really translate this type of work to the work that you're doing in your own states around adolescent care. That's me. So what started a lot of this conversation, certainly in Ohio, and I'm more than likely in many of your states as well, is just looking at how well we do in general. Certainly this is national data, but the state Ohio state data is not very different. Just nationally thinking about how well we do in terms of providing preventive care for adolescents. And it's not a very good picture. This data is from, I believe, 2009. The most recent iteration, I think, is yet to be published, but it's not very different. And only about 38% of adolescents have had a preventive care visit in the past year. And of those, only a fraction are even getting all the recommended preventive services that at least the evidence suggests is important with adolescent well visits. And I think part of the reason why this happens is because us as providers are not meeting those needs. We're seeing adolescents when we're not providing them the care, not completely understanding what that care should look like and what it should include. Another piece of this puzzle, though, which I know many of you are working on in your own states, is just recognizing that adolescents aren't coming into the office, at least in a clinic sort of more standard sort of way, and therefore we just lack opportunity sometimes to reach these adolescents. And that's what that second gray box of data is showing, again, from a little less than 10 years ago. But on average, adolescents are coming into the doctor's office maybe once or twice a year, and that's for a non-preventive care visit. That's an ankle sprain or a sore throat or some sort of emergent need that needs to be taken care of. For actual scheduled well visits or preventive care visits, that's certainly less than one time a year, and the recommendations, certainly from a medical society standpoint, is an annual well visit once a year. What's nice about, I think, the adolescent well visit in particular is it really allows, as a medical provider and as someone interested in improving adolescent health, it really provides a wonderful framework for addressing a lot of the medical needs and social and mental health needs of patients and their families. So for those of you who don't do this on an everyday basis, just kind of keep in mind this is what we mean by an adolescent well visit. This is what we're aiming to accomplish, sometimes in as few as 20 minutes, but hopefully more when we see an adolescent once a year. That includes taking a thorough medical and family history and any updates on that since the last time you've seen them. That includes all the pieces that are part of a sports participation evaluation, which is something families oftentimes will seek in other settings other than their primary care clinic. So that includes certain parts of a physical exam that really helps us make sure that they're healthy and safe to participate in sports, but it also includes certain medical types of questions that also give us a sense for risk factors or things that may be something to evaluate or at least consider in terms of their health for participating in sports. It also, though, includes for that comprehensive well visit just a more thorough head-to-toe exam beyond just the sports participation piece, in part just to make sure we're not finding any other abnormalities or issues, and really to make sure development is on track the way we'd expect it to be. What's probably most unique about an adolescent well visit compared to other well visits at different ages is that confidential psychosocial assessment. This is that one-on-one time that we talk about that's important to have with the medical provider and the adolescent without mom, dad, guardian in the room, where we really get a chance to check in with what's going on in life in those psychosocial realms. So sometimes you'll hear us use the word the HEADS exam, which is really a mnemonic that helps us remember all the important domains to talk about and really address and evaluate. So we're asking about how things are going on at home and at school and with friends, what activities they're involved in, resiliency skills, or getting a sense of their coping skills, any potential substance use, sexuality, reproductive health needs in terms of potential contraception needs or STI screening or just preventive messaging. This is also where we're doing a lot of our screening for mental health concerns like depression or anxiety or just stress, and again, those coping skills. And safety in general, both at home and at school, as well as safety and beyond that. So that really is, I think, key to a good comprehensive well visit for an adolescent. And then there's the preventive health screening and immunizations that really are sort of laid out by the national recommendations, those evidence-based guidelines that many of us talk about. So are they due for chlamydia screening based upon sexual activity? Are they due for HIV screening based upon a universal recommendation for all 16 to 18-year-olds somewhere within that age range, as well as a few other. Immunizations, as you know, come up as a big part in these adolescent years, especially around that 11 to 12-year-old range, but even after that, especially if we think about annual flu immunization recommendations. And then sort of peppered in throughout this entire visit is the anticipatory guidance we're hopefully giving both patient and families in terms of safety and stress reduction and normal development and things to anticipate. That's really what we mean by a comprehensive and prevention-oriented well care visit with an adolescent once a year. And so as you can imagine, and as Kristen mentioned, it really acts as a wonderful framework for just their current health, but also for prevention and hopefully long-term health as they maneuver into those adult years. And I think I highlighted with those red asterisks for many of you who may not necessarily be working on adolescent well visits within your state, but may be working on pieces of that adolescent well visit framework. So for those of you working on or trying to improve immunization rates or preventive screening, some of you are working on nutrition and physical activity and obesity and just general healthy habits. Many of you, I believe, are also working on transitioning to adult care. Those pieces are naturally part of the adolescent well visit, so it becomes a really useful tool to address more than those things, but really the whole adolescent and their family. And certainly as a provider, our ultimate goal is to make the most of every opportunity, especially with adolescents who we may not see very often in the clinic. And the adolescent well visit really gives us a nice framework for accomplishing that. The adolescent well visit in particular, though, certainly in Ohio, but even beyond that, really is this nice natural alignment of common goals that we see. And that's certainly one of the things we're doing in Ohio is really trying to leverage these common goals. So as I think about it as just the sort of clinician and the patient level, most of us every day are looking to improve the quality of the care that we're giving, and certainly patients are expecting the best quality of care that they can get as well. For many insurance providers and payers, the HEDIS metrics, those national metrics that really line out what quality a particular provider or particular organization should be working at, the HEDIS metrics play a really important role in driving how they're doing and how they're perceived by the organizations that they're really trying to ensure for. And adolescent well visits are one of those national HEDIS metrics, as are many of those pieces of the adolescent well visit. So we talked about immunizations, both HPV as well as all adolescent immunizations, chlamydia screening. Those are national HEDIS metrics that, as we see, are already part of the adolescent well visit. And then certainly for those at sort of the policymaker, community partner, government sort of arena, many of you I know certainly are working on or have worked on some of the goals as part of your own maternal and child health grants, and in Ohio as well. And again, part of what our focus is for that grant is specifically the adolescent well visit, recognizing how potent a tool it is for addressing all of those pieces in that larger picture of improving adolescent health. This slide's a little messed up, so stick with me here, but what I wanted to just show you was a little sort of snapshot of how we're really trying to drive that conversation and that natural alignment around the stakeholders within our state, but really as an example of how this may play out in your own states as well. So as I think about sort of our local/state level, we have this Ohio chapter of the American Academy of Pediatrics, which many of our speakers, Liz and Sam, are a part of, which is really just a medical organization. It's a national medical organization that all of our states also have state chapters on. So many of your states probably have their own chapter if you haven't already met with them or made connections with them. But they are designed to really support pediatricians and pediatric subspecialists like adolescent docs or infectious disease docs and all those sort of pediatric specialists in their clinical care needs. And in particular, I think one of the things that the Ohio chapter does really well is a lot of work around improving the quality of care for many pediatric issues, including adolescent well visits. So you heard when they were talking about some of the projects that Liz has worked on, many facets of pediatric care that we have statewide quality improvement collaboratives on. Then at the sort of more state level, we have Laura in the Ohio Department of Health and all the other people working with her with the maternal and child health grant here in Ohio. And again, you have this sort of layer of work and interest in improving adolescent well visits, not just the rate of how often those are happening, but really the quality of those encounters. And luckily for us, through many conversations, we're really trying to meld all these common agendas, so we're working together to support the same thing. And then as I mentioned, nationally, you have these HEDIS metrics that really influence a lot of the stakeholders out there in terms of what's being put on the top of their agenda to have to pay attention to, and so by default becomes an opportunity to have conversations around how can we help one another. And so if all of these letters and green arrows were lining up, all what you're seeing here is those stakeholders come, again, with natural alignment around adolescent well visits, come from the clinical side of things with providers and hospitals, as well as insurance payers and insurance companies, as well as policymakers and partners. But you really can throw in lots of other potential stakeholders into this conversation as well. Things like pharmaceutical companies, as we think about where those adolescent immunizations come from and how they have a stake in this common agenda as well, or schools, both high school or middle school, as well as at the college level, and educators in those systems. Clinical specialty, so obviously I've been talking about things from the primary care sort of pediatric and adolescent medicine side of things, but you can think of the infectious disease doctors and their interest in improving HPV vaccination rates and other adolescent immunization rates is just sort of one example. Mental health providers, as we think about depression screening and mental health screening that are naturally part of an adolescent well visit. Our foster and juvenile justice system and how entities within that arena are really trying to improve not only the health of the juveniles within their system, but really helping them in that transition to the adult world. Other social movements. So many of you may have heard the Young Invincibles, which is a national organization that really focuses on helping that transitioning to adolescence into the adult world. There are organizations like that at your state levels as well that really may be important and useful stakeholders to really have conversations with. and anyone else that I'm missing that you may have already made connections with or are already thinking about as we're talking about this. But a lot of what it boils down to is, I like to call it serendipity, but really it means talking to a lot of people and really making connections, whether you know it or not at that moment, of how these conversations and how these connections line up so that we can really be working together and much more effectively by working together. And that's kind of what happened to some extent with our Ohio chapter of the American Academy of Pediatrics, and now as we move closer to really doing some formal work with the Ohio Department of Health as well. So as I already mentioned, the Ohio AAP national organization, but a very strong state organization here in Ohio supporting pediatricians and pediatric subspecialists. And they developed the TALK program, that Transforming Adolescent Care Learning Collaborative. It's a statewide clinic-based, so they have basically a number of clinics throughout the state that are all working together as part of the collaborative with a sort of common goal and support through the Ohio AAP to improve their adolescent well visit rate as well as the quality of those visits. So this is what it looks like in a picture. So starting in June of 2015, we ran our first wave, about 9 months, with our first set of clinics. Like I said, there were sort of two main goals. One was to improve the adolescent well visit rate, and the second one was to improve the quality of those visits. So for that first wave, we focused very broadly on just whatever that particular clinic that was involved in the collaborative, whatever sort of quality metric they wanted to focus on, that's what they focus on for the quality. So some people were focusing on mental health screening and some on reproductive health and others on nutrition and physical activity counseling and others on doing that confidential head psychosocial tool consistently. We're just wrapping up wave number 2 now, which started in August of 2016. Again, that sort of consistent focus on improving adolescent well visit rates for this group of clinics that are involved in the collaborative. And now that quality component, we're chose to focus more specifically now on reproductive health. So what we mean by that for this particular wave has been consistently integrating a HEDS exam, so that confidential one-on-one time with the adolescent and the provider, but also trying to consistently improve documentation of reproductive counseling, on HPV vaccination, and on STI screening if that's appropriate based upon the clinical needs for the patient. And we're sort of in still the planning stages for future waves, but hopefully I've given you enough of a argument as how the adolescent well visit really acts as a wonderful framework for many offshoots from here: mental health, nutrition and physical activity, injury, coping skills, resiliency, transitioning to adult care. There's many, many iterations that I think we see as opportunities with this improvement in adolescent well visits. What the collaborative looks like physically for the clinics that are involved is a lot of things. So I've kind of listed a few of them here, but as a structure, it really is run by the Ohio AAP and the staff that they have, including Sam, who is our quality improvement expert, and Liz, who acts as sort of the main coordinator in keeping everything on track. But the collaborative is structured such that it's what we call a whole clinic engagement. So it's not just strategies to improve the care that happens literally just between the patient and the provider, but rather the entire environment for the adolescent. So a lot of focus on how can we improve the interactions with the front care staff and adolescents and their families, and nursing, and ways to really create just an adolescent-friendly environment. We have, again, that QI expertise, and the Ohio AAP did a lot of the background work for the clinics involved in the collaborative, really to find what those evidence-informed strategies were and really pull them together into a really nice program that clinics can really just participate in and have a lot of that groundwork already laid for them. And then we do both baseline as well as monthly data collection on these metrics that I said that we follow to really give us a sense of how we're doing and what strategies seem to be successful, which ones don't, and how do we sort of make modifications based upon that information. There's a lot of physical materials that the Ohio AP also provides to the clinics that are involved. What we call our birthday postcards, really as a way to engage the adolescent. Hey, remember, it's your birthday, happy birthday, you're due for your annual well visit, and hey, it's free, or at least it is at the moment, for their annual well visits. As well as, like I said, some of those posters and clinical scripts and ways to really help educate families and front staff and so forth about important adolescent health information. There was a lot of education built into the TALK program, so there was a one-day in-person learning session where we covered a lot of quality improvement training and social media training, as well as adolescent medicine kind of specific stuff for the care they're providing to patients. But we also do monthly action period calls where we review the data from the month prior, as well as an adolescent topic for that particular month, and that varies from month to month depending on what we need. And then there's incentives built into the quality collaborative. So probably one of the most potent incentives we've had as part of the collaborative, and we see this with the Ohio AAP's other collaborative as well, is what we call MOC4 credit, or maintenance certification credit. And this really is just credit that medical providers, in particular pediatricians, need in order to maintain their certification as a pediatrician. So, and they need it every 5 years, so you can anticipate that it's a really useful credit to get that's not very easily found in other places. But as well as trying to create credit opportunities for more than just the physicians that are involved, but the nurses as well, gift cards to help defray some of the costs that can go towards their front staff, and then really helping to link some of the incentive programs our payers have, for instance, with United Healthcare, who happens to be one of the insurance payers here in the state, but also is one of the financial supporter of the TALK program, helping them really get the message out about those incentive programs and how those can financially benefit the clinics as well. So with that, I'm going to pass it over to Sam.
Thank you, Dr. Dritz, and good afternoon, everyone. Thank you for joining us. I'm the Quality Improvement Consultant for the project, and I'm just going to be delving into some of our higher-level outcomes within our work within TALK and highlight the improvements that we've made through this learning collaborative environment, and then hitting upon some of those components that Dr. Dritz mentioned in her slide on the WellCare visit, how that all kind of ties back into those components. And at the end, I'm happy to answer and go a little further into the measures and any of the improvements that we made during our question and answer time. So to kind of bring us back to that bird's eye overview that Dr. Dritz had provided with our goals for each of the iterations that we've done, with our first wave and first learning collaborative within TALK, our overarching theme was to improve the adolescent visit rate by 10%. The number of adolescents that had come in within the past 13 months and were up to date on their well visit care. And then as she had also mentioned, we're really looking at not only improving that rate, but once they're in the office, providing that comprehensive adolescent care at all the visits. And the clinic got to choose the area that they wanted to improve and to target that improvement by improving it by 25%. And the topics that they looked at were injury prevention, obesity, looking at nutrition and activity counseling, mental health, and then reproductive health. And then we leveraged some of our key drivers to help move those practices towards these two goals of not only improving their adolescent visit rates, but their clinic chosen areas by looking at office reminder systems and outreach, how we could incentivize participation not only internally but externally with the patients, encouraging teen-centered care, how we could really embrace missed opportunities and convert any chance that we had to comprehensive adolescent care and get those adolescents up to date, and really work to raise the importance around the well visit, not only in the clinic itself, but with the families that the clinic was seeing. So starting off with some of our successful strategies from Wave 1, we really wanted to encourage the practices to look at their patient population and start to develop some best practices that really worked for their providers, their clinic location, and the patients that they worked with, and looked at using front desk surveys. So those were developed, provided to practices, and helped them to determine why patients came to their office that day, both for well and non-well visits, and what would be the best mechanism for patient outreach, be it mailers, calls, any texting systems that we could utilize, or social media. And text and postcards were noted as the prime form of communication with the patient and families. The project team didn't really ask about postcard mailers, but those ended up being one of the most successful strategies of reaching out and reminding families and patients about the visit that was coming up or that they were due for a visit, as Dr. Dritz had mentioned with that annual well child visit reminder for their upcoming birthday. And in looking at those, within those 3 boxes that are on the screens, postcards and phone calls both had about 0.25% of the time resulting in a visit being scheduled for that well child visit. And then for the practices that did utilize texting, about 5% of the time, those visits, that outreach resulted in a scheduled visit. And then from those outreach reminder strategies that were utilized, the attendance rates of a visit that was scheduled was 70%. So looking at a good turnaround for those that did actually schedule a visit, for them coming back and attending that visit. And looking at social media and texting as some innovative ways to work with this patient population. Texts were stated by the families and the patients as being useful for appointment reminders, and then the practices also got a bit of social media training at that one-day kickoff session for how to engage adolescents and their families via various social media outlets. And looking at the data that we have, the first of which is the missed opportunities that were available and how we could convert those visits to adolescent comprehensive visits. So educating not only the families and staffs about the importance of these, the difference between a well visit and the sports clearance or physical, and how they could utilize recall reminder strategies, calls that families have made into the practice to convert, when time was available, those visits that were on the books to comprehensive well visits. And looking at the data that we have here, each of these graphs have a 3-month retrospective baseline, and then our learning collaborative started in June of 2015, and we have both the younger adolescents in the light purple from 11 to 17 years of age, and our older adolescents 18 to 21 years of age in the dark purple or blue. And we can see very clearly with the sports clearance, our practices had a significant drop-off in those missed opportunities in the form of a sports clearance. So those were able to be converted to a comprehensive well visit through some of the mechanisms of recall reminder, or if there was time during that clinic schedule. There was a bit of a trending downward with our ill visits as they worked to convert those and having those adolescents up to date on their care, but not as dramatic of a change as we saw with the sports clearance. The next item that's on the screen are our monthly attendance rates, those adolescent well visits, as well as what the providers looked at in terms of their chart reviews. So looking first at the monthly attendance rate, this really is, and to break it down, each month looking at the total patient population of adolescents that, for most practices, have been seen within the past 3 years, and of those patients, how many of them were up to date or had an adolescent well visit within the past 13 months. And looking at both the adolescents 18 to 21, we saw about almost a 10%, 7 to 10% improvement in the monthly attendance rate or the adolescent visits up to date, and then about a 4 to 6% improvement in our 11 to 17-year-olds. And then looking at some of the more easily shifted and changeable items around our counseling topic documentation. Again, these are those self-selected areas from our practices, looking at whether it was nutrition or depression, reproductive, and injury prevention. Those all had a retrospective baseline and then monthly data collected. And then we had a practice that selected and started to work on the head screening in that light gray, line to have improvements made around that and shifted their focus towards that area. And we can see a nice improvement in our nutrition counseling from its baseline of about 30% up and to the goal that we had set around 90% at the end of the collaborative, and similar trending with that depression screening and then some of our other measures as well. So some of the challenges that we had in Wave 1 as we were working on this, first and foremost, looking at the data that we have and what it means for our learning. It was a great learning opportunity, but it was a small sample size. So we worked with 4 participating practices, all from various practice settings. And as we worked to figure out what worked best and get some best practices, one of the challenges that we saw and faced was technology. So how we had legal concerns regarding texting and how to push that through legal in some of our institutions and in specific small practices, how they could start to utilize that innovative and most frequently mentioned way to contact families for recall reminder was a challenge. And then looking at how to eventually embed this into the system and the various mechanisms we have, not only through texting, but the electronic medical record and embracing those. So kind of working and navigating through those. And then despite some of our work on recall reminder strategies and the various mechanisms that practices reached out, we were still facing the issue of the no-show rate, despite all the work that providers and practices put into the postcard mailers, any texts that they had used, and the phone calls. So trying to figure out how we can circumvent that issue and build upon that, as that was kind of a universal theme that we had seen. So moving then to Wave 2, our second learning collaborative and second iteration of this, with a couple months in between our first wave and the second wave, looking to modify, hone our focus a bit, still keeping our eye on the adolescent well visit rate and working to improve the adolescents that are up to date on their care, but then focusing, as Dr. Dritz had mentioned, more on a reproductive health area, improving our HPV vaccination administration rate by 25%, using that HEADS comprehensive psychosocial screening tool, or the series of questions at 90% of our well visits, and then looking to document Bright Futures reproductive health counseling, and then comprehensively Bright Futures counseling at 90% of our well child visits. So again, very similar data. On the top left is our monthly attendance rate, and we're still gathering the data that we have as this collaborative will end at the end of this month. And then the second chart is documentation, looking at those reproductive elements that the providers were reviewing within their randomly selected charts. The one thing to note here, and we have additional data to look at in a couple of slides moving forward, data was a bit of a challenge for this collaborative and this wave, and it was difficult to get some of that patient population data around the adolescent attendance rate. And that's where our partnership with UHC really came in, and we were able to compare apples to apples. So while this reflects what practices have provided, I think having that HEDIS metric and that global picture of what was happening was a little better way of feeding back data to our practices. The more easy picture, and something that provided insight onto what was happening in terms of the well visit encounter and what was happening around reproductive health counseling, was that documentation chart that we have here. And in looking at the more clean improvements around the use of the HEAD screening tool in light blue, our reproductive health counseling in purple, having all components of Bright Futures counseling, spreading the gamut from mental health, nutrition and activity, injury and violence prevention, substance use and abuse, reproductive health, having all components of that noted appropriately in kind of that tealish solid line. And then looking at if it was appropriate to order and receive a chlamydia screening, as well as our components being appropriately documented for the HPV series, and whether or not that immunization was provided at that current visit. I mentioned that we worked with UHC to get some of our data and to help compare apples to apples. And While this data is a little further back than what the previous charts had shown, this gives an overview of the HEDIS-specific rates. So looking specifically at HEDIS metrics, we're looking at data for the year of 2015 in dark in the green line and the year 2016. And for that year that's noted on each of the lines, whether the patients that were eligible to attend a well child visit had attended said visit, and the number that we end up at the end of each year having met that criteria. And we can see in green, which is prior to our current practices participating in TALK, that they had about 33% of their adolescents up to date on care. And looking at the blue line, by the end of November, and of course now we're in April of 2017, they're at about 37% of their adolescents, those eligible adolescents, were up to date on their care. So looking at the improvements that have been made as they close out the year of those eligible patients that have made the appointment and have attended said appointment to be up to date on their adolescent well visits. The other component in going towards our HPV series and administration of that, be it the first, second, or completing the series, data gets a little muddy because as we started this collaborative, we had the 3-dose series as the only recommendation. And then in October of 2016, that new CDC series recommendation came out, and we tried to retrospectively go back and translate what that recommendation was to how many of their adolescents were actually now done with this series, and the series was complete. And then for those that would need the 3-dose series, kind of what that looks like. So with this data, I think the two important lines are the light blue, which is the previous 3-dose only recommendation for the series to be complete, and then having that new recommendation made in dark blue, anyone that was eligible for the 2-dose series or the 3-dose series having completed it. And looking at, for your adolescent patients that were eligible and had completed this series, more of those individuals are doing so. And the thing that's also nice to note is in the yellow line, those individuals from just a random selection of charts, we're seeing less have not received any dose. So that is also trending downward since November of 2016, letting us just have that additional validation that they're getting the doses and that we're working to complete those series. And one of the things that I think was kind of an unexpected but a nice component of this, seen as our main focus was getting the kids in the door and attending those adolescent well visit rates, was seeing the nice increase in those individuals completing their 3-dose series. And this is only for females, and this is looking at our UHC data, again, that nice apple-to-apple comparison that we wouldn't have had if we hadn't had this partnership. So looking at the top graph on the left side, in 2015, UHC's final HEDIS rate was about 14%, and our TALK practices in the previous year were about 16%. UHC has maintained about that 14% immunization series completion rate, whereas our TALK practices, if you average out those last couple months, are right at about 27, 28% of those adolescents are receiving and completing, those female adolescents, their 3-dose series by their 13th birthday. So it was a nice kind of boost and information to receive about the reproductive component that we had been looking at with our immunizations for these TALK practices. So as far as successes, seeing that trending improvement in our HEDIS AWC, or the adolescent well care measure, but from my perspective and being within data, that partnering with UHC on the HEDIS data collection, really looking at population health and those measures, not only on the adolescent well visit, but the HPV metrics really help provide our clinics with some valuable insight from what insurers are seeing, as well as the improvement efforts that they're making. And then looking at how this collaborative that's working with several practices is continuing to expand, and we're improving our collaboration, and we're getting hospital system buy-in. So noting that hospitals are seeing within their institutions the importance of adolescent well visits and flyers being posted on that, and the use of TALK resources or information from TALK being spread throughout those environments. So with that, I'm going to pass it on, with challenges. Data collection, I think, as I alluded to with the adolescent well visit, was getting that population metric for audits that practices did on their patient population. And without having UHC to partner with, I think it would have been a little more difficult to feed that information back to practices, let alone them pulling that information to kind of get an accurate picture of what their well visit rates were. Looking at maximizing billing for these time-intensive adolescent visits, we actually spent our last action period call delving into that and how they can cover this wealth of information with just a short amount of time, and working with insurers to make sure that they're doing it appropriately. And then that goes back to the time component of squeezing all this information into a very short well visit time frame. And then looking specifically within the state of Ohio, I think QI fatigue is a challenge that we're facing, and how we can take the information and the lessons that we've learned and share this on a smaller scale that isn't necessarily just a 9-month learning collaborative that's very time and resource intensive for the providers that are participating. And now I will pass it over to Liz Dawson, where she'll go over some of the information about the backbone of TALK.
Great, thank you very much. What a great overview of our program and then a deep dive into the data. So thank you to my colleagues, Dr. Dritz and Samantha Ansels. My name is Elizabeth Dawson. I am the Chief Operating Officer with the Ohio chapter, as well as the TALK Program Manager. So try to advance the slide here. Oh, okay. So here within the chapter, I always operate on the philosophy that an idea without a plan is just a wish. So we had a lot of wishes back in 2014 from providers, from the state, from other stakeholders in adolescent health care, that we really needed to hone in on a few adolescent issues that would really impact the overall care and then the overall trajectory of the adolescent's health as they move into adulthood. So these needs assessment and gap analyses components are the fact of that Dr. Dritz already kind of reviewed as the sports clearance reminder, our sports clearance visit versus the full comprehensive adolescent well visit, that there needed to be some education and some distinguishing between the two, and a reminder to families of the importance of a full visit. A reminder recall strategies. How do we reach adolescents? Cell phones. Do we talk to their parents? Do we send a postcard? Do we send an email? What kind of terminology and eye-catching marketing is really going to make them feel as if they're going to own these materials and have a sense of ownership over their health? Office staff motivation. So everyone is overworked and underappreciated, and how do we really motivate the office staff to make them feel like they're more than just a touch point, that they're really the entryway and the gateway of adolescents receiving this health care that's going to change their lives? And then transform the relationship that the adolescent has with the primary care provider and the primary care office. A lot of them are pediatric-centric with characters on the wall and toys and whatnot. How do we make them feel as though when they're going in there, they're still talking to someone that can relate to them and someone that they can confide in and talk to about some of those issues like reproductive health, nutrition, depression, anxiety, et cetera. So that's a pretty lofty goal. How do we put that into work here? So, you know, we circled the wagons. We gathered all the partners that we thought that we needed to have at the table, and then we had a lot of meetings, a lot of, you know, introductory committee meetings. We kind of divided things into an advisory team and a work group. So the advisory team really advised on clinical content, really helped kept us focused on, you know, what we're doing for the adolescents and making sure that we're following Bright Futures guidelines and that we're following what's happening in the actual visit. And then we have the work team, the folks who are going to help with marketing and program design and QI development, and et cetera. So once we had all of the players and everyone knew their part in the school play, we started having meetings, because when you have your plan and you have your goal and you have your outcomes, you need money to make it happen. So we had several meetings with different managed care organizations in Ohio, as we thought that that was a natural fit for this program. Not only could they provide funding, but they could also provide resources in terms of data and assistance with their outreach coordinators that can go out into the practices and provide them resources. So we ended up partnering with UnitedHealthcare Community Plan of Ohio, and that's been a partnership that has lasted over 2 waves, and they will continue to support us as we continue with talk into the future. So we have our plan, we have our quality measures, we have our quality improvement format that we decided to kick off with, which was the IHI Breakthrough Series. If anyone familiar with quality improvement knows that that's sort of the beginning, ground level for any program, so that we can, run that pilot. And then we decided to pick a launch date and go from there. So here comes the fun part. So we marry the advisory team and the programs team feedback, feedback into one succinct format, so that we have an exact script, an exact agenda of what we're going to accomplish. And then the best part is creating the logo, the name, the colors, the marketing materials, and kind of putting all of that together. You recruit your physician teams, and then you do another cross-check. Make sure that you hone your outcomes to make sure that they are measurable, so that you're not starting these practices off with goals that are just going to frustrate them and that they cannot obtain. And then you start planning your in-person meetings and subsequent webinars that Dr. Dritz alluded to earlier. So over the past 2 waves after the launch, we've had some definite challenges in learning, and I like to think of them as growth opportunities. Samantha referred to a few in her talk, so I'll just sort of talk about the ones that she didn't mention. So Dr. Dritz had a great plan to embed clinic-tested tools to maximize and ease documentation. So she created the Adolescent Clinical Care Document section on our website. It's an online resource that we use to share with our talk practices and really anyone that we send this link to that has everything that has been used. So it's screenshots of different EMRs, different screens, different documents that people use in the practice. So we really want to have a one-stop shop of all the resources that are available. And then sort of capitalizing on every opportunity that we have. So, everyone has different strategies, different ways of getting to there, but we all have the same finish line. And that finish line is the same, to reach one patient at a time and help improve their care one adolescent at a time. So as we move this work toward the future, we are definitely in a great transitional phase. We've had a really successful pilot, and then we really took a deep dive into the second wave, and now I think we're ready to spread. And by spread, I mean more activity across the state of Ohio, putting it into more of a hands-on, shorter, smaller format so that it's not a longer learning collaborative, but that it's more of a sort of a concierge service where we can have a trainer go out to practices and, assess what needs the particular practices have within their 4 walls, and then make the changes and adjustments based on that. Maybe recall isn't a problem for them. Maybe it's just transforming the relationship with the adolescent, or, there's various different situations. Maybe it's a brand new barrier that we haven't even heard of yet. So we'll be working on that. We're also working on sort of putting together, we have an adolescent immunization program. We have an app, a mobile app called Fast Facts that's for childhood and adolescent immunizations. But I'm working on developing a teens-only button on there, and that's going to have teen-focused well-visit information, teen-focused health general information, as well as HPV, direct answers and talk about HPV, so that teens have a educated, well-sourced place to go when they have questions about that in particular immunization. So we're looking at taking a lot of this and spreading it nationally. We really want, since this has been such a successful program, and we have so many great people who have put so much institutional and clinical knowledge into this, that I think it's ready to package up into a pretty box and spread to any state that would be interested in having that. And then we still want to continue to capitalize on the alignment between the clinic's care goals and their medical education needs. So we're always cognizant of the MOC Part 2, MOC Part 4, and the continuing medical education, and then the nursing credits and CEUs. So we want to make sure that people are getting the proper credit for the work that they're doing, because it is definitely a lift to take on a new part of your practice. And then we want to leverage our position with our pediatric and adolescent medicine providers to create lasting improvement in primary care and the adolescent health provision. So like I said, we all have the same goal we took off, and we all at the very end of the day just want to help improve adolescent care, and then we want to be able to use the resources like the registries and the different data collection pieces to show at the end of the day, that to put a number on that improvement and really show that we have been moving forward and helping these practitioners and helping these families. And with that, I will pass it over to my Laura.
All right. Hi, everyone. Just like to say thank you for this opportunity to share our work in Ohio, and thank you to my partners on the line for what they have shared. Rena, can we have the next slide, please? So what I'm going to do is really talk about how what has happened over the last 7 years in Ohio and how we have capitalized on partnerships and leveraged resources, and how we connected the work of the AAP to the Ohio Department of Health Maternal and Child Health Block Grant, and then also the Ohio Adolescent Health Partnership. So really this work started before 2009, but in 2009 there was really an emphasis of bringing physicians together to provide guidance to the Ohio Department of Health adolescent work. And they started on a preconception health project, and they received some funding, and we're working with AMSHP to do an adolescent provider survey, which was launched and analyzed in 2010. And from that, what they did, they identified really some work that was being done for adolescents, what services were being provided, and then by whom. And so they expanded beyond just the physicians or pediatricians, but to nonprofit organizations, family physicians, and others. And then from that, they said, you know, there's a lot of needs for adolescents, but how can we prioritize these? And then from this work, the Ohio Department of Health can't do it alone. The physicians that were at the table partnering with ODH said, we can't do this alone. We really have to expand our scope. And the scope needs to expand beyond what the capacity is of government. And so that multidisciplinary group said, all right, what are the priorities that we need to focus on? And so they identified behavioral health, which was mental health and substance abuse, injury and violence prevention, reproductive health, nutrition and physical activity, and sleep. And they decided that to really put this work into action, they wanted to step away from the Ohio Department of Health so they could do some advocacy and policy work. And that's whenever they became the Ohio Adolescent Health Partnership. And so I provide some staffing support and glue, but they created their own leadership. And we have leaders that every other year we switch from clinical leaders, and then the next year we have those that are from nonprofit organizations or community-based organizations. So we always have a nice balance and a voice of who is providing services and trying to reach those adolescents. And then what we did was we said, all right, of those priorities, we really need to create a plan. And so we wrote our first strategic plan. And from that strategic plan, we said we need to promote this work. And so we've held a number of conferences So we've had 3 major conferences. We've expanded our strategic plan. And then what happened is that at a national level and within the maternal and child health block grant world, the adolescent well visit started to come forward as a priority. So in my role as the adolescent health coordinator at the state, I started bringing those messages to the Ohio Adolescent Health Partnership. And then at that same time, and Michelle used the word serendipity, the AAP was starting to work on the TALK program, and it was beginning to build. So through our partnerships and collaboration, we kept working on and learning about all the components and issues that were needed to move the adolescent well visit forward. And so then around 2015 or 2016, as we started to write and make plans for the Ohio Department of Health block grant, and our agency identified adolescent well visits as something we wanted to commit to, that's whenever the Ohio Adolescent Health Partnership decided that they would add a 6th component to our priorities, which was access to care. And what I was doing was continuing to educate, and our partners, Dr. Dretz and other pediatricians that we had at the table were providing leadership. We were informing all of those topic-specific partners on how a well visit can provide a foundation for their health topics and how they can, in turn, promote a well visit back through the work that they do. And so we have moved forward, and so now here we are in 2017. So next slide, please. And so what we've been doing is using the block grant as our foundation. We're using that to build and enhance our partnership. We're using programmatic structures, our survey data, and claims data to move forward. We now have a great relationship with Ohio Medicaid, and they've given us some wonderful data where we can examine county data as well as provider data within the adolescent well visit. And one of the things that I wanted to share is that there's a lot that's happened here. There's so many different levels of work that I think that it can be overwhelming, but to start with one initiative and one piece of this and let that build and progress over time, and to continue to find where the puzzle pieces fit together for that serendipity. And as we're moving forward in Ohio in our block grants, that we have 5 things that we're really focused on is always continue to engage stakeholders and how they fit together. Also, to continue professional development. The TALK program is housed within the Ohio AAP, but then our block grant is bringing the other medical associations together, the Ohio Academy of Family Physicians and the association that manages our federally qualified health centers, and the Ohio Medicaid that I mentioned, to the table. How can we continue to expand professional development across all of those professions? And then also expand the CQI project as well. We also want to look at policy and how can we take the learnings from TALK and other projects that we have. What policy and procedural changes need to be brought to light to make long-standing sustainable changes? And then marketing. You saw some of the pieces that TALK has, but how can we take those pieces and expand within social media and also direct media marketing pieces as well. So those are also some examples of how we're going to take smaller initiatives to build to a multi-tier approach. And I know that we're tight on time here, so I'm going to close with that. So I would just like to thank everyone for their participation in this and welcome questions.
Thank you, Laura. So if you have questions, please do type them in, or this is the hour at the end of the session and you need to get off, please feel free to type your questions or comments into the evaluation form that you'll run into at the end of the webinar, and we will respond to you from there. If anybody has a question, please feel free to press #6 to unmute your line or type into the chat box. But in the meantime, I just want to say thank you to Michelle, Samantha, Elizabeth, and Laura for your time and your hard efforts in Ohio and sharing that with us today. Rena, can you forward to the next slide, please? Give one more, please. So just for future references, we have a few more webinars coming up. The State Partnerships for Adolescent and Young Adult Healthcare Quality Improvement, which will really take this concept of partnerships and drive it into some of the models that we're seeing in our states that are working well for the adolescent young adult health quality improvement work. And that's on April 20th. And then Rena, next slide, please. Also, in a complementary learning community, the Marketing and Adolescent and Young Adult Well Visit learning community, tomorrow, April 11th at 2 o'clock Eastern Time, will be the webinar Millennials and Founders Equal Market Disruptors. So if you can see from that, it should be a very intriguing webinar on marketing to young people about the Well Visit.